Please, today's video is for only doctors. If you are not a doctor, please bypass this video because you will have a headache for nothing. Just run and scroll to another video. Listen. So today, I happen to have a mother who underwent a cesarean section 1.5 weeks ago. She comes back with sepsis, serious sepsis. So now the resolution, according to the exam and the findings and investigations, we're supposed to do X-laparotomy, opening the abdomen, reaching inside the pus or welcome dash. Now we had to look for the source of the pus. What is the source of the pus? Inside the abdomen, there is what we call the greater omentum, the policeman of the abdomen. It had gone to the previous incision on the uterus, and it is where it had engulfed. It was very septic. Now, what are we learning today about this? Doctors, you always open people. And when there is something inside the abdomen, maybe for anybody, peritonitis, whatever you find out that is not supposed to be inside the abdomen, the omentum shifts to that region. Have you ever asked yourself, how does omentum recognize something foreign in the abdomen? This was today's discussion in the theater. So under which physiology does omentum recognize an infection or a pathogen? This falls under 3 categories. Listen to me. 1, innate immunity, or what we call inflammation physiology. How does it occur? The omentum is rich in the following: macrophages, neutrophils, B lymphocytes, milk spots, or what we call immune cell aggregates. So when there is, for example, a foreign body, perforation, bacterial contamination, sepsis, the damaged tissues and the bacteria release the following. 1, it releases pumps, or what we call pathogen-associated molecular patterns. Or either it can release DAMPs, damage-associated molecular patterns. The damaged tissue also releases cytokines, for example, interleukin-2, tumor necrosis factor alpha, interleukin-6, and also releases cytokines. So these are detected by partner recognition receptors, the PRRS, on omental cells. Of course, this is a classic chemotaxis. Number 2, how omentum recognizes a pathogen is chemotaxis and the cytokine signaling. These inflamed tissues produce chemical gradients, and eventually the omentum responds to 1, complement fragments, for example C3a and C5a. Omentum also responds to bacterial toxins and pro-inflammatory cytokines. So now these create a chemical gradient, and the omentum now moves towards the highest concentration. So here physiologically, it is immune-mediated chemotactic migration driven by inflammatory mediators. Number 3, how omentum recognizes a pathogen is mechanical mobility factor. Remember, the omentum is long, it is fatty, highly mobile, and not tightly fixed. So because of gravity, peristalsis, and diaphragmatic motion, it physically drifts and adheres to inflamed surfaces. So inflamed surfaces become sticky because of fibrin deposition. Inflamed surface is vasodilated and hyperemic. So now the fibrin helps the omentum to adhere and wall off infection. In summary, the omentum recognizes infection via 1, innate immune sensing. That is the PRRs detecting the DAMPs or either the pumps. 2 is chemotaxis towards inflammatory cytokines. 3 is fibrin-mediated adhesion and mechanical mobility within the peritoneal cavity. So this is not a conscious movement. It is immunologic and inflammatory physiology. And clinically, this is why now in appendicitis, omentum walls it off. In perforated ulcer, it plugs the perforation. In abscess, it localizes infection. And this prevents generalized peritonitis.